Axial spondyloarthritis. Clinical features. The cardinal feature of axial spondyloarthritis is inflammatory back pain and early morning stiffness, with low back pain radiating to the buttocks or posterior thighs if the sacroiliac joints are involved. Symptoms are exacerbated by inactivity and relieved by movement. Musculoskeletal symptoms may be prominent at emphasis, may be episodic, and if persistent can present as widespread pain and be mistaken for fibromyalgia. Fatigue is common. A history of psoriasis, current, previous, or in a first-degree relative, and inflammatory bowel symptoms, current or previous, are important clues. Physical signs include a reduced range of lumbar spine movements in all directions, pain on sacroiliac stressing, and a high emphysitis index. Entheses that are typically affected include Achilles insertion, plantar fascia origin, patellar ligament entheses, gluteus medius insertion at the greater trochanter, and tendon attachments at humeral epicondyles. A number of validated clinical questionnaires such as the Bath Ankylosing Spondylitis Disease Activity Index (BASDI), Bath Ankylosing Spondylitis Functional Index (BASFI), and Ankylosing Spondylitis Disease Activity Score (ASDAS CRP) can be used to assess disease activity and functional status in ankylosing spondylitis. Though newer assessment tools are being developed that are more specific to a diagnosis of axial spondyloarthritis, such as the assessment of Spondyloarthritis International Society Health Index (ASAS-H). Investigations. The diagnosis is aided by ultrasound or MRI of emphasis, or by MRI of the sacroiliac joints and spine. Other findings may include raised ESR and CRP, although these can be normal, anemia, and positive HLA-V27. Fecal calprotectin is a useful screening test for associated inflammatory bowel disease. This figure shows magnetic resonance imaging appearances in sacroiliitis. Coronal MRI showed T1 inversion recovery (STIR) sequence showing bilateral sacroiliitis in axial spondyloarthritis. Bone marrow edema circles is present around both sacroiliac joints, which show irregularities due to erosions. Now the management. Patient education, NSAID use, optimal once daily or slow release taken at bedtime, and physical therapy are key interventions at the outset. For severe and or persistent peripheral musculoskeletal features of spondyloarthritis, both sulfasalazine and methotrexate are reasonable therapy choices. These medications have no impact on spinal symptoms or disease progression. In patients who fail to respond adequately or who cannot tolerate NSAIDs, progression to biologic therapy with either TNF inhibitors or the IL-7A inhibitor, secukinumab, should be considered. Anti-TNF therapy is effective for both the axial and peripheral lesions of axial spondyloarthritis, but it is as yet unclear whether anti-TNF therapy modifies the natural history of the disease. Now the prognosis. With such a recent definition of disease, the markers of prognosis in patients diagnosed with axial spondyloarthritis are not fully understood. It is clear that axial spondyloarthritis can remain mild and or episodic in many patients for many years. HLA-V27 positivity, high persistent CRP, and high functional incapacity are likely to be markers of poor prognosis, if not markers of extension ultimately to ankylosing spondylitis.